Hi, I'm Gerard Fennessy from the Victorian Intensive Care Network. The following podcast was recorded at our August 2014 meeting. Associate Professor David Pilcher, Chair of ANZIC's Core and Intensivist at the Alfred Hospital in Melbourne, talking on the reducing mortality of sepsis in Australasian intensive care units.
Introduces someone who's going to talk something about sepsis. Actually, probably covers roughly what I'm going to talk about, because I'm going to talk something about sepsis, but not a lot specifically about sepsis or sepsis management, because I can't claim to be any expert in it. I'm going to talk a little bit about a study that I was involved in. That I was lucky to be involved with some other people who got it published in quite a big journal, and talk a bit about the background to that study and a bit about the background to where that data came from, because it came from the ANZIC's Core registry. And I'm assuming that most of the people here have worked in intensive cares, and even some of the microbiologists at the back over there I know have worked in intensive cares. And if you've worked in an intensive care in Victoria, or indeed in most of the intensive cares in the rest of Australia and New Zealand, even if you don't know you've been doing it, you've been collecting data that's gone to the ANZIC's registry. If you worked in a unit which gets one of those horrible aortic paper forms that you've got to fill in, you'll know it because you've had to fill in exactly those values that turn up on this registry of data. If you work in a unit like ours, you don't realise that you're collecting it, because when you're filling in the admission form, it's going into an electronic database that sends the data off to us. But that's the data that has allowed us to perform this type of investigation analysis. But I'm going to start you off with a little story. And this is a story of a guy who is a family friend who was admitted to an intensive care, not in Victoria, in another part of Australia. He's a retired anaesthetist. He's diabetic. He drinks as much as many other retired anaesthetists I know. Was admitted to an intensive care in a metropolitan area of Australia. And what I didn't realise at the time, but I realised not long afterwards when I actually heard more about his experience of his time in the ICU, is that Michael is actually our median patient. He's the most common patient that turns up in our ICU. He was 65 years old. The median age is 64. He's about 85 kilos, about 170, just over 170 centimetres tall. And he was admitted with a diagnosis of sepsis. He didn't need intubation, but he needed vasopressors. And I don't know what his creatinine and his renal function was, but he remembers people talking around his bedside about hemofiltration. So presumably he had some degree of renal dysfunction. He never went on to a filter, or doesn't remember it. But he's the kind of patient that turns up in all of our ICUs. If you look at the mortality for 60-year-olds admitted to intensive cares in Australia and New Zealand, it varies between 5% and 50% at different hospitals. And that variation comes from... I wanted them to do that a little bit later, because I've got a song. No. That variation predominantly is driven by people's severity of illness, and different ICUs admit patients of different severity of illness. So that explains that difference between a mortality of 1 in 2 and a mortality of 1 in 20. It doesn't explain all of the variation. Some of the variation is due to how well you look after that patient. And it's that kind of variation that we measure when we look at the data from the registry that allows us to essentially report on the outcomes of your ICU and your departments of health. The departments of health around the country get reports, and your ICUs get reports that has a dot on it that lists how your mortality compares to ICUs around, for similar ICUs in your region and across Australia and New Zealand, after taking into account that severity of illness. And you need that severity of illness to adjust for that huge difference in outcomes that we see. And the registry that we run, that you lot collect all the information for, is pretty big. Can you see that picture? I can't. There's meant to be a picture of Australia. But it allows us to it allows us to get a picture of the intensive care resources around the country, and the number of beds, the number of admissions. There's roughly 130,000 admissions reported to the registry every year. There's a database of 1.5 million patients now. There's probably another 15 to 20,000 patients that we don't get reported to us, and they're predominantly in either small rural ICUs or private ICUs that decide not to submit data to us. And we've also got information on CLABSIs, and there's a paediatric registry, but it gives us a huge data set that allows us to tease down into small differences between groups. It allows us to look at incidence and prevalence. It tells us what we do to patients. It doesn't tell us what we should do to patients, but it does give you a real indication of what happens. And this is one example here. And these are patients with sepsis or infections. And as your temperature goes up, your mortality for an admission to ICU actually goes down. Now that doesn't mean that we should be either treating temperature or warming patients up. You need a randomised controlled trial to tell you that. But it does tell you that temperature by itself, although it might be useful for identifying the patient with sepsis, doesn't necessarily tell you that that patient is more likely to die if they have a temperature of 40 compared to 39. And it allows us to. And when we did this, we also got the people in the UK to run a similar analysis, and they found exactly the same thing. So this is consistent. We can look at white cell counts. We see a similar thing with white cell counts. If you've got a low white cell count or a low temperature, that's very bad. But to make those comparisons, and I mentioned about severity of illness, we need to know bits of information. If I want to compare Michael's chances of surviving in one ICU to his chances if he was admitted to another ICU, I need to take into account both the variation in numbers, patient risk factors. You can't compare a paediatric ICU to an adult ICU. Now, there is a reason why I've got a koala up here. Part of the reason why there's a koala up here is because my wife said that I should have put a fluffy animal into any talk. But the other reason why there's a koala is that this is Sam the koala, who was made famous in the 2009 bushfires because a fireman gave him some water, and then the picture of this koala being given a drink of water then went viral around the world. Sam the koala represents a risk factor for sepsis. For a start, he was a burns patient, and he's a koala, and koalas have an intrinsic immune deficiency, which means they're susceptible to chlamydial infections. And Sam died of a chlamydial infection a number of months after his admission to the local sanctuary where he was treated for his burns. So you need to know your population that you're looking at when you're comparing patients with sepsis. The other thing that the registry gives us the information to look at is that it allows us to quantify what people's risk is. So if you consider someone's chance of dying, we can quantify it and say the most of that chance of dying is actually due to how acutely sick you are and the biochemical values that you measure. So your creatinine, your pH, how low your blood pressure is, how high your pulse rate is. That's what most of it. The person's age only accounts for 15% of it. Their chronic comorbidities only account for 8% of it. They account for about the same amount as whether you decide the person has a treatment limitation. The source of admission, whether they're ventilated, are much, much smaller. But you can't, with this size of a data set, you can quantify what someone's risk is. And this takes us to the fact that sepsis admissions are common. If you consider sepsis as it's just coded in the data set, it's actually the most common single sort of diagnostic group. If we apply a more stringent definition, apply the STIRS criteria, that you've got to have a white cell count that's either less than 4 or more than 11, and temperature less than 36 or greater than 38, you then move some of those patients don't qualify for those criteria. But once once you apply specific criteria, just under about 15% of our patients who present to Australian ICUs have sepsis, and about a third of them have septic shock. And this data set can accurately identify those patients. That percentage of sort of 15% or just under 15% is greater in metropolitan ICUs. So those of you that have worked in places like the Northern, Frankston, will have a greater percentage of patients with sepsis. This will be your bread and butter. These patients are slightly less common in tertiary ICUs, but that's only because there's a throughput of cardiothoracic patients coming through that account for a proportion of the patients. So on the background of sepsis being a common problem, on the background of patients like Michael, my friend Michael, being an admission to ICU, we thought it would be good to look at sepsis. There's lots of publications about sepsis. There's lots of publications of magic bullets for sepsis. There is no consistent magic bullet, magic treatment that has been proven with the test of time to actually improve outcomes in sepsis. There are a number of trials ongoing looking at early goal-directed therapy type approaches, of which PROCESS has now completed. And when we started looking at sepsis, we knew these trials were going on. And more to the point, the bloke in the middle there, Ronaldo, who many of you will know, who is Australia's sort of premier researcher in intensive care medicine, he knew that if we looked at this now as an epidemiological study, there was a good chance that we could swing it into a good journal that was being edited by one of the principal investigators in those other trials and get it published, because we could provide some good epidemiological evidence to tell you and tell the researchers of those trials what the background incidence and mortality for sepsis is. So this was a calculated gamble for publication. We were lucky. The two people on either side were the people who did most of the work. Michael Bailey is a statistician. Maija Kaukonen is an intensivist from Finland who was working here at the Anzac Research Centre. And really, they're the ones that did the work on this study. And what we did was look at the data set. And in that data set, and looking at essentially a sort of 12, 13-year period, there were just over 1 million admissions to ICU represented there. We take out the readmissions, we take out those who've got a bit of missing data, and that left us with just over about 1 million patients where we had good epidemiological data, of which 100,000 were admissions with sepsis. And we could apply those tight definitions to the sepsis. And the things that we were a little bit surprised to see is that sepsis is actually going up. Admissions to ICU with sepsis are progressively climbing. And they're climbing in rural ICUs, they're climbing in tertiary ICUs, they're climbing in metropolitan ICUs. If we look at septic shock, the incidence of septic shock presenting to our ICUs is also climbing. This isn't getting less common, and these were using tight criteria. But although we've got an increasing incidence of sepsis, we're seeing a decline in mortality, and we're seeing a progressive decline in mortality. Now, if we send this off to a journal, so somewhere like JAMA, where we were lucky enough to get this published, they immediately go, okay, are these statistics that you're showing us, are they real? Because the easiest way to make these numbers look better is for us to admit patients who either don't have sepsis or start counting the nurses in the ICU, start counting the doctors in the ICU. Increase your denominator so it looks like your mortality is getting better. But we could show them that isn't the case, because we can show that the actual sepsis admissions are going up, and we've got a hard definition for sepsis. And then said, are you admitting less sick patients? And because we have that information that can allow us to measure severity of illness so accurately, we can see that severity of illness in those patients is actually not declining. So we're actually admitting patients with the same severity of illness, and that's also borne up by the proportion of patients with septic shock that we're admitting. That's actually progressively increasing. And the implications of this were, well, why is it getting better? And I don't know. I can say it's not due to all those magic bullets, because there haven't been any consistent magic therapies for sepsis. Having said that, this sort of information does also tell you that, because most of the time when people plan their studies, they plan their study 1 year, I don't know, they might plan to do their study in 2005, but they use data from 3 or 4 years before when the mortality was higher. And by the time they get to do their studies another two or 3 years later. So every study is inherently underpowered. There isn't an adequately powered study out there. But more importantly, when we looked at the mortality of every other admission coming into ICU, ICU admissions overall are declining at exactly the same rate. So this is not a sepsis alone related phenomenon. And we're seeing the same decline where there's essentially a halving of mortality between the early 2000s to the more recent years, which is due to the processes that we apply within our ICU, the care that we give within our ICUs, the nursing systems that we have, the training for the doctors, the increased awareness of adverse events. No one's going to do a trial of an adverse event. We're only going to improve adverse events by increased safety and quality within our ICUs. And that decline in mortality is present across almost every single diagnostic group. It appears to be coming at potentially a cost. One of the things that we were also asked to show was that we weren't just measuring our deaths at an earlier time point, and we're not. But what we are doing is we're progressively seeing more and more patients discharged to rehab and chronic care facilities. And that's increasing across the board. It's increasing. Sepsis patients is not quite increasing quite as fast as it is for the other diagnostic groups. But even though there's a difference in those black dots and white dots statistically, in reality, when I look at those, that just looks like an increase across the board at the same rate. So we're producing more survivors, but possibly we're producing more survivors with chronic disabilities, with unknown and uncertain long-term outcomes. We don't know. This isn't measured at the moment. Now, the other thing that this information gives us the opportunity to do, and I hope this projects, is it gives us the opportunity to actually play and get out a little crystal ball and have a look what might happen in the future. That's the mortality for sepsis over that decade, progressively declining. If you put a straight line through it, that actually comes down. It hits around about my wife's birthday in March 2025, actually, which if it continues as a straight line would actually mean that there'll be no more deaths due to sepsis and we can all go home. Of course, if it was going in a straight line, then severe sepsis would hit at a different point, and sepsis in the young, well septic would hit at a different time as well. So actually, a straight line isn't the way to look at this. And the top set of dots are septic shock. The middle set of dots are overall sepsis. And the lower sets of dots are sepsis is the mortality for sepsis in the under 45s with no comorbidities. So if you're going to look at a cohort where you try and attempt to say this is the attributable mortality to sepsis alone, this is as close as we could approximate to. And if you draw those lines out, that's what we'd expect. And we had the luxury of having data for that decade, which we've subsequently been able to update. And over the next 3 years, we've exactly followed that predicted decline in mortality. Now, what that means for us is that means for clinical trialists, if you're going to plan your clinical trials, and plan to do them in the late 2016, 2017, 2018, you're going to be looking at mortality rates that are going to be pretty close to 15%, and you need to power up your trials. I probably think that this is the kind of, if we're tracking along that curve, this is the kind of expected outcomes that we should aim to keep up to. If we're not meeting those outcomes, perhaps we're not doing quite as well as we should be. But we're not going to know until we actually see the information coming through. And this is it's nice and smug of me to stand up here and say this is what's going to happen in the future. But it's only with the benefit of hindsight that we can attempt to put these sort of predictions up there. So, really, in summary, I could have put up here one other summary comment, which was, if you want to get a paper published in JAMA, get Ronaldo to help you out and phone up his mate who's the editor. But sepsis admissions are actually increasing, mortality outcomes are declining, and need the knowledge of the severity of illness to actually interpret them. But most importantly of all, we need to look beyond hospital mortality, because as we create more survivors who are going to chronic care facilities and rehabilitation facilities, we need to know what the functional outcomes are for those patients and what their long-term survival outcomes are. And at the moment, those are complete unknowns to us. Thanks very much.
Thank you, Dave. What hope does ARISE have?
Oh. I don't know. I'll be very interested to see what the outcomes of ARISE are. Process, ARISE and PROMISE. Process, the US one. PROMISE, the UK trial. ARISE, the Australian and New Zealand one. They've been harmonised so that, although they have slightly different protocols and slightly different inclusion criteria, their data collection is exactly the same, so that they can have a multi-individual patient meta-analysis at the end of those trials. Process showed absolutely no difference whatsoever between the two groups. I don't know what's going to happen. I have a sneaking suspicion, but I'm waiting to see. We'll have the results of ARISE are being analysed at the moment, and are going to be available in October. And the PROMISE trial isn't going to be available until the end of the year. But by the end of this year, I reckon we'll have an answer on whether early goal-directed therapy for sepsis is warranted or not, or whether it's just because we're giving good care.
Thanks for listening. For more great talks from the Intensive Care Network, go to intensivecarenetwork.com.